So this is going to be a very casual talk today, so interrupt me if you have questions along the way. And I'm just going to kind of talk about my experience here at Holy Family over the last 40 years. So I'm talking about advances in surgeries. Into my topic. So back in the 80s is when same-day surgery really started here, and we had a 7-bed same-day surgery unit. So it's in the same location where same-day surgery is now, but our beds start with room 1 over there. So we just had 1 through 7. It was a very narrow little unit when they started there. We also had our first clean air room opened up, so I'll talk more about that. Sterile processing in 1984, that area where Central Supply is, that part of the building was added on to this building, and that sterile processing area was like tripled in size from what it was before. We purchased our first lasers during that time, and we also, by the mid 80s, we started with the Meditech computer system. So in the 80s, we didn't have a lot of minimally invasive surgery before this. So we were doing all open procedures. Like Tom said, you had a gallbladder, you probably had a 10-inch scar from your gallbladder surgery. If we did any type of colon cases, you had an incision from the bottom of your sternum to the top of your pelvis. Everything was big in the 80s. We started doing total joints when we built our first clean air room, but before that, it was mainly fracture care that we did for orthopedics. Or if you had a rotator cuff tear, that was an incision almost all the way around the top of your shoulder for that type of a surgery too. Patients got admitted the night before their surgery, so we didn't do any morning admissions for any of the patients. Anesthesia would visit the patient up on the med-surg floor. They'd obtain their consent, answer any questions. We had a prep and holding area, so in the morning they would come to prep and holding, but the night before, one of the prep and holding nurses would visit with the patient. She'd make sure their lab work all looked good, that there were no surprises in the morning that would cancel the surgery. She'd make sure the surgical consent was correct and answer any questions that they might have. Then the morning of surgery, they went down to the prep and holding room, and in that area they would get their IVs started. We did a lot of hair removal, which is something years on they found wasn't really beneficial, but it was, if we would do the whole leg. If we were operating on their ankle, if we were operating on their knee, we shaved them from the hip all the way down to their toes on that operative side. We started doing some epidurals for pain control for some of the larger incisions, and anesthesia would place these epidurals in this prep and holding area. Then they would go on to the operating room. So in the 80s, we did surgery in the morning because everything was open, big surgeries, and in the afternoon, we processed our own supplies. So as we did surgeries in the morning, our instruments would go down to sterile processing. They would be cleaned and disinfected. They'd come up onto a cart by us. What is our operating room number 3? That was our room where we folded all of linens. We had a lot of reusable linens back then. So laundry would send us a big thing of linens, and our drapes that we would make the sterile field, our towels that we made the sterile field, we had to make packs of these. So in the afternoon, we really visited and you really got to know your coworkers because we were assembling all these linens. We knew what went in all of the instrument trays, so then we had to count the instruments, put them in the trays, and then we did that all afternoon until we worked 6:30 until 3. So we would get all of these, and then they would go down to sterile processing, and they would be run through the sterilizers and processed for the next day. We also had a lot of sterile supplies in the operating room, and we worked off of paper preference cards. So they were kind of like a big recipe card, and back in the 80s, every surgeon had a different way to do everything. So you really had to look at their preference card, and people would make comments like, and the kitchen sink, because some of them had very long, lengthy lists of what they needed for their procedure. And a lot of the stuff was like on standby, but you still had to pull all those instruments and get them on the case card for their surgery. So once we got to Meditech, then when they came into being, we could automate these preference cards, and they were on sheets of paper. So we did that. We also they have a big registration book. We had a big book, and that was the OR schedule. So we had every day had a page, and then you would write in who was doing what surgery at what time. At that time, we also had the surgeons do first come, first serve scheduling, which was not efficient, because I might be surgeon A and I schedule a case at 7:30 and I'm done with at 9:30 because cases took longer because it was these big incisions. And then surgeon B might put a case on now at 10:30 to follow. So that 9:30 to 10:30 was useless because the procedures were longer and nobody could, fit a case in then. And then I might be surgeon A and I want to put a case on, but now I can't put it on until 11:30 because surgeon B is in the middle of when I want to do my surgery. So in the 80s, then we started doing block surgery. So surgeon A knew that Monday was my day and I could operate case after case, which made it more efficient. The office also knew that this was my day, because when it was first come, first serve, they were in the office running to the OR, back to the office. They did a lot of that. And then they were late for surgery because things took longer in their office and for them. And in the 80s, we also had the game of, if you can't get this surgery on, I'll take it to Memorial Hospital. And Memorial Hospital had the same game being played with them because we both did this first come, first serve. So things were much easier for the surgeons and the offices once we started doing this block scheduling. So the clean air suite in the 80s, this is it demonstrates the airflow. So the patient would be in the center of the room, and we had 2 large fans at each end to help with the circulation of the air. But we had big filters in that space at the top that would filter the air. So the air would come through that filter, and the idea was the most filtered air would come down and spread out across the patient. They don't show this as well in the bottom of this picture, but when we started this, it was you did not want anybody to get an infection in their joint. So all of the staff wore space suits. They had a plastic reusable helmet that had a fan in the back because you got very hot under the OR lights that are in that bottom picture and in all this garb. So you had a cord that ran down to your belt, where you had a belt with a battery that operated this fan. But this reusable hood, the helmet part of it, had a big vacuum cleaner hose that was attached to an exhaust pipe that came down from the ceiling maybe 4 feet. And that would take your air that you're exhaling out of the building. So that was the big thing with that. Then they were also, you needed to keep people away from the sterile field. So we had this track here, we had big plexiglass walls that we moved and we put around the operative field here. So then you had an inside circulator who could check the patient, make sure they're still in the right position. If anesthesia needed anything and the surgeon wanted anything, that inside circulator would take care of that. But maybe they asked for something that wasn't in the room, so the outside circulator would run and get that. Back then in the 80s, we also did a lot of patients would donate their own blood in case they needed a blood transfusion. So we were very much in the practice of giving their blood back to them while they were in the OR. So that outside circulator would go to blood bank and get their blood and bring it up there for them. Then I would say probably in the 2008-ish range, this concept kind of went out of being a fad or whatever, because they realized in addition to the airflow, really what was more important was pre-op antibiotic and the timing of that pre-op antibiotic to prevent infection. And like we didn't shave the extremity in the case that we did before. So we were doing skin preps before to make sure that area was cleaned. And we were part of a surgical collaborative with other hospitals in the state of Wisconsin that reported our data, and we showed we didn't really need the cleaning room like we did before. This was, I of course couldn't find any old pictures. This is probably a more sleek model of a CO2 laser, where it was much bigger when we had a CO2 laser. But the CO2 laser was the first laser that we had, and the GYN surgeons were using this for different cervical procedures, and it even had attachments that you could use it intra-abdominally. So if a patient had endometriosis in their abdominal cavity, they would use this laser to ablate that and get rid of that endometriosis. The general surgeons, they used it if patients had wound ulcers, mainly diabetic foot ulcers and things like that, and they would get rid of the bad tissue with this laser to promote growth of new tissue. These lasers were very expensive when they first came out, and it seemed like they were always upgrading, improving. So when it came time for us to buy our next laser, we chose to do a rental program. So there were medical companies that came in, and then this way we could always provide the latest technology to our patients because they had the latest lasers to rent. So that's what we did with that. So the 1990s, we became Holy Family Memorial. We merged with Memorial. And at that time, the decision was made that all of the surgeries were going to be done at the Western Avenue campus. So for us, it was great. We didn't have the I'll take it to Memorial or I'll take it to Holy Family. We were all one. The nurses that came over and the surgical techs that came over, they were very well experienced with our surgeons. It was just a different location. So it was a little growing pains for some because they had to learn our location and where we kept things and things like that. But we had like a association of operating room nurses that the Memorial nurses belonged to. So we already knew them. So that made things easier for us. So it was a great experience. So later, I missed this probably, but later in the 80s, we got rid of that room where we processed instruments, and we made a second clean air room. So that happened like about 1989. So we really needed, once we had the whole volume from Memorial and us in one location, we were quite busy in the 90s. So we needed that extra room that we put on, and that gave us 9 operating rooms. The building where the older part of the OR was built in 1966, and we had 7 operating rooms in that location. But same-day surgery, we're starting to do more minimally invasive surgery now. So the gallbladder patients now are going home the same day. We had kidney stones. I'll talk about that in a little bit, but those patients used to be overnight stays too. So we doubled the size in same-day surgery to 22 cubicles at that time. So laparoscopic surgery, this is a picture of laparoscopic surgery. So now we had our 2 big rooms that we used for total joints, but we also needed that size of a room for our laparoscopic surgery, because we now had we had 2 of those TV monitors, because you're standing on each side of the patient, the surgeon, the assistant, or the surgical tech, and it was easier to work if you could see what you were doing by just looking straight across rather than turning your head and looking at this. Laparoscopic surgery, really in the 80s, we were doing that with the gynecologists. They were the ones that really started with that, with doing like ovarian cysts or small procedures like that. And then it spread to the general surgeons. So this allowed small puncture wounds where they would put this trocar in, which is like a sleeve, and then they would pass instruments like this through those openings. And they have like a valve in it that as soon as you took the instrument out, the valve would close and it would open as you put the instrument in to manipulate. And the gallbladder is what they have up on that screen. And they have a little hook like this that's connected to cautery that's removing the gallbladder from the bed of the liver there. Let's see. So then we started doing things like hiatal hernia repairs were being done laparoscopically. Inguinal hernia repairs were laparoscopic. We were doing uterus hysterectomies laparoscopically. So just about everything started turning laparoscopically. So this is ESWL, stands for extracorporeal shockwave lithotripsy. So this was a unit that we rented. So we had this unit come in and it was for kidney stone treatment. So the patient would lay on that table, and if it was a right kidney stone, that, I don't know what they call it, but this part right here would be on the right kidney to break up that kidney stone. This could be moved to the other side of the table if it was a left kidney stone. So the way that worked was it would shock, using ultrasonic waves, it would shock the stone to break up the kidney stone. So we had the patient on a heart rate monitor, and between every beat of the heart, it would shock the kidney stone. So you wanted the patient to kind of have a consistent heart rate, so we weren't in there all afternoon or all morning trying to break up the kidney stone, because if their heart rate was too slow, it took forever. But this technology, I believe they're still using, we were using it. It will break up the kidney stone these were for stones that were like in the pelvis of the kidney, and the ureter runs between the kidney and the bladder. So if there was a kidney stone in that ureter, we would try to push it up to the pelvis of the kidney, and we'd have a stent in the ureter to keep it up where we wanted it while we would shock it. Then we would remove the stent at the end of the procedure, and it was in small enough pieces that it would go into the bladder and the person would excrete the kidney stone. We had certain nurses that were trained to operate this equipment, like they went to school for that, and I had 2 different staff doing this. And we had them, at one time, we had them coming twice a month. That is what we had for that. In 2000, with the Centennial Building Project, which built on the Cancer Center, it also gave us 2 larger ORs than even the 2 clean air room suites, and it also brought the cath lab to us. And as we were doing a lot of total joints in those rooms, and we also wanted to do the laparoscopic surgery at the same time. So we got rid of one of the ORs, was a hallway that added on. We got rid of that to make a hallway to add on this building project that we did. The cath lab allowed us to treat patients who were experiencing a heart attack, and we started doing that later in 2000. I have to lie to say if that was 2008 or what year that was. But this was really a game changer for people who were experiencing a heart attack to have better outcomes by not sending them 30 miles north to Green Bay for that procedure. We started hiring fellowship-trained surgeons, so they had the latest experience with minimally invasive surgery. And we also started offering spine surgery. We kind of dipped our toe into spine surgery by having some of the neurosurgeons from Green Bay at first came down here and to offer to us. We also had a surgeon from Brookfield that came up here. And then we decided this is a need for Manitowoc County. We're going to hire our own fellowship-trained spine surgeon. Okay. So in the 1980s, we were doing angioplasty of like leg vessels, arm vessels for different things. But then in the 2000s came stenting. So they were able to put a stent in place. If we did a bypass, if there was a blockage and we couldn't get the balloon through the blockage because that plaque in that artery, the yellow part, can be very dense and very hard. And if we couldn't move it, we needed to remove that blockage in the artery. And we would then have maybe a 4-hour procedure where we would take a vein from the leg and cut out the part of the artery that was occluded and put the vein in. And if they didn't have good enough veins to do, we used a Gore-Tex PTFE graft that we would put in that place. So then stenting, really, you would balloon it, and then that stent is deployed over the balloon, and then you just open the stent, and so we're probably done in an hour and a half versus a 4-hour surgery. A much better outcome for the patient. Arthroscopic shoulder surgery. So Dr. DePiric and Dr. Carl DiRamondo were our first surgeons that we had here that we started doing closed shoulder surgery. So through this scope over here, they also have another port that you can't see over there where they would run water into the shoulder to extend the shoulder so they could see what was going on in there. And then this is a camera connected to the scope that's in that shoulder, so they could have that up on a monitor to see where the rotator cuff tear was. And then this device over here is a shaver, and there's different shaver blades that connect to that would shave away the roughness to make it smooth so that you could move your shoulder without any clicking or anything sticking in your joint. He also could do, they have grafts that if the shoulder, there was nothing left to save, but you still need that rotator cuff to kind of hold everything together, we would put a prosthetic graft through the portholes, and he would suture it through those portholes with that. So of course that was these are all same-day surgery patients, and it leads to a faster recovery time because you don't have the incision all across the muscle on the top of the shoulder. Endoscopic sinus surgery, we started doing that. And we have, this isn't a great picture, but the patient would have a CT done of their sinuses. So we work very closely with radiology with a lot of the surgical procedures. So this is the CT scan of the patient's sinuses up here, and then the physician has a scope in the nose looking up to this. This is a polyp over here that he's going to remove. And it's a very narrowed area that you're working in. So this, the scope and the shaver, we use a shaver in the sinus also, was connected to a CT image guided system. So it would tell them exactly how much you should trim, how far you can be in the sinus safely. So it would show on the image there, it would show like where your shaver was and where your scope was once they have that inserted in there. So that was something that was a big improvement over surgeries from the past. Dr. Campbell started offering a LINX procedure, and this is for acid reflux. So he laparoscopically would insert this little magnetic band that's only about the size of a quarter, and he would put it around the esophagus. there's a lot of working with Dr. Ann Clam or another GI provider to do studies to test to make sure that this is the problem with the pH. They'll test the pH of the esophagus to make sure that yes, it's acid from here is causing a higher pH up there, and we want to keep that acid in the stomach where it belongs. So this LINX procedure, it will open to allow food to pass into the stomach, and when there is no food there to pass through the stomach, it then contracts to keep the acid back in the stomach. So that was a big thing because hiatal surgery, hernia surgery, sometimes that's also caused by a hiatal hernia, and that was a big open procedure that we started doing laparoscopically, and then we would use kind of a banding technique where this, sometimes they needed to adjust things, and this just was a much safer procedure, I think, and it was newer technology that made it possible. This didn't show up very well, but the surgeon here, we're doing minimally invasive spine surgery, and if they had a bulging disc, this is a tube here called a metric system, and they could put that with image guidance. So this is a fluoroscopy unit on top over the patient, and that's the view of it. So now in addition to the TV monitors, we also have X-ray taking up a lot of space in our rooms with the fluoroscopy. But if they had a bulging disc, they would look at the level, put in this tube, and then they would be taking out pieces of this bulge disc. Then they would go to the next, there was a larger side. Once they did smaller, then they put a larger tube in, pull a little more until they relieved the bulging disc in that area. All right, 2010s, we did the first endovascular aortic aneurysm repair. So your aorta is like your main artery in your abdomen. And that open procedure probably took us about 2.5 to 3 hours to do that procedure. So this was much, and you're cutting through a lot of muscle. It's the aorta is along your spine, so you're doing an abdominal approach, moving all of the intestines and everything out of your way to get back to where this aorta aneurysm is. I'll talk a little bit more about that in a different slide. And then we started, so we've been doing total hips and knees for a while now, and now we're perfecting things. We have all of our infection control measures down, and they started offering an anterior approach, and I'll show that on another slide too. And now we switched from the Meditech system over to the Cerner computer system, and Meditech was kind of an older workhorse that had kind of seen its day, and a lot of other hospitals had already switched to Cerner or Epic at that time. Us being a standalone Holy Family Memorial, we were kind of too small of a hospital for Epic to be interested in it. So that's kind of why we went with Cerner at that time. So this is a picture of the endovascular abdominal aortic aneurysm. So we always want the graft to be below the kidneys, which where it is, this is an aneurysm. It should be a straight tube here, but it's a weakening and outpouch of the aorta. And then this goes into the iliac arteries. Sometimes there can be aneurysms in that area also. Sometimes the aneurysm isn't this big, and we can just put in a straight tube graft rather than this bifurcated graft going into each of the iliac arteries. So now this is kind of similar. Well, I guess I should read my notes because let's see. So Dr. Milan Jordan and Dr. Schwahowski and Dr. Gentile. So we had the interventional cardiologist who have always kind of gone through the groin up to the heart to put in the cardiac stent. They worked with Dr. Jordan, who usually did the open procedure. And of course, he went to training for all of this, and the three worked together, and we did our first endovascular aortic aneurysm repair. The advantages for this is there's much less blood loss, because like that other angioplasty picture, we go through the groin up the iliac artery, we place a catheter over the aneurysm, and then this graft is threaded up over the catheter to take care of the aneurysm. So they had a faster recovery, and this then, rather than a 7-day length of stay, we reduced it to, it might have ended up going to just overnight, but initially we kept them 2 days. So that was crucial. And then ultrasound is a big thing to detect that we have an aortic aneurysm. So this is kind of the lateral view of a hip. So in the beginning, when we started doing hip surgeries, we had a big long incision because we did a posterior repair. We're also cutting into a lot of muscle with that posterior approach. Then we went to a lateral approach that made us have a little smaller incision. And then finally we went to the anterior approach that was more of a muscle sparing approach for that. So with these smaller incisions with the total joints, and we also got much better with pain control. Anesthesia was offering like nerve blocks for pain control in that area. So we started sending patients home the same day. And we worked with physical therapy, because we had physical therapy and same-day surgery to make sure they could ambulate and move about the room safely before we let them go home. But I would say the pain medication got things under much better control for the patients, that they felt like they could go home comfortably. And now I was just trying to see what's new. Well, our affiliation with Freighter happened in the 2020s, and that offered us a lot of capital security, I guess I would say, bigger purchases. We went to the Epic computer system since being with Freighter, and they helped with the implementation of that. And now Dr. Lamoni's latest thing that he's doing is a bikini approach. So then rather than being here, the incision's more like here. So that's the latest. And then I was looking to see what else they're doing since I'm not here. And this knee kinesiography is something that they're starting to do in the clinic. And that's a picture of that. So this isn't surgery, but I thought it was kind of cool, so I wanted to throw it in there. So this is done by a physical therapist in conjunction with the orthopedist. And they have this external device on you that's hooked up to a computer while you're walking on the treadmill. So if people are having pain in their joint, or they're having a functional deficit, like they can't straighten their knee completely, they can't bend their knee as far as they can, this will give them a 3D assessment of their knee function while they're in motion on the treadmill. So it'll do the flexion, extension, abduction, moving your knee like cross midline, adduction away from your hip, or even just rotating your leg. So I thought that was kind of cool. So I kind of think that's something to look forward to, something we're doing. Any questions? Hopefully I didn't bore you too much. I like it, so but thank you for your attention, and
Thank you.
have a good day.